Doctor.
Ha? Email.
Email. Yes.
Email jangan nampak you. Apa tajuk topik you?
Saya tajuk nebulizer and also MDI. Okay. Let me share my screen.
Siapa ni? Luffy Hadi siapa? Siapa tak datang lagi?
Saya datang.
Ha? Luffy Hadi Fidaus. Ada dua ni. Fatin Hana ni?
Saya Dato, tapi saya punya laptop lag, so saya buka untuk dengar voice dekat phone.
Buka apa?
Saya buka Zoom meeting ni dalam phone untuk voice.
Okay, start.
Alright. Okay. Assalamualaikum warahmatullahi wabarakatuh. I'm Dr. Fadzil and also my fellow friends. Rabbi Shrahli Sadri wa Yassirli Amri Wahlul 'Uqdatam min lisani yafqahu qawli. And today, inshallah, we have several presentation on regards on the procedures, medical procedures. And I will be the first presenter. My name is Ibn Fikran, and I will present about nebulizer and also MDI. So I will go first to nebulizer. So what is nebulization? We must understand what is nebulization. Nebulization is a therapy that delivers respiratory drugs directly into the lungs. Nebulization or atomization is a process of conversion of liquid into a fine mist of spray. So we go to nebulizer. So what is nebulizer? Nebulizer is a drug delivery device used to administer medication in the form of a mist inhaled to the lungs, where it converts a liquid solution or suspension into aerosol droplets that is suitable for the patient to inhale. Nebulizers are commonly used for treatment of asthma, cystic fibrosis, chronic obstructive pulmonary disease, and other respiratory disease or disorders. Nebulizers may be easier to use, especially for children who aren't old enough to properly use inhalers or adults with severe asthma. So how does nebulizer works? A nebulizer delivery system consists of a nebulizer and also a source for compression of air. This compression of air causes airflow to the nebulizer that causes the change of medication solution into a mist. Thus, this will inhaled by the patient. So when inhaled correctly, the medication has a better chance to reach the small airways such as the bronchioles, and this will increase the medication's effectiveness. So this is nebulizers. So what are the common medication that is usually prescribed through nebulization? So firstly is bronchodilators, such as salbutamol, which is indicate for acute exacerbation bronchial asthma or acute exacerbation chronic obstructive pulmonary disease and also severe asthma. Next is corticosteroid, such as beclomethasone, which indicates for severe asthma. Next is anticholinergic, such as ipratropium bromide. The indication is similar to bronchodilators, which are acute exacerbation bronchial asthma or acute exacerbation COPD and also severe asthma. And lastly is antibiotics such as streptomycin, colistin, and also azithromycin, which is important for chronic prolonged chest infection. So what are the components before that? For the medication prescribed, we also non-medication such as normal saline. So in wards, they use medication with normal saline, which is 1:1 ratio. For example, we give 2 ml of salbutamol and also 2 ml of normal saline, and this is important to improve the effectivity of the medication to produce aerosol and mist by the machine. Next is the components of nebulizer. So these are the components of nebulizer, which includes the machine itself, which comprises the air, the hose, and the medication cups, which is a chamber or a space to put the medication, the delivery system such as the mask and also the mouthpiece. And for the mask, there are a variety of sizes and we must choose depending on the patient. So what is the importance or differences between mouthpiece and also mask? For the mouthpiece, there is no leakage of nebulized drug to a solution to the environment because the mist is directly entering into the mouth and into the respiratory tract. For the mask, there is a presence of leakage of nebulized drug solution to environment because some masks have holes on it. For mouthpiece, there is also deposition into the nasal passage and also face. Next is the mask. There will be deposition of solution into the passage of nasal passage of face. This is because the mask is covering the mouth and also the nose of the patient. And also the mask is easier for the patient to use. And in children, we use mask, which is more easier for them to use. This is the steps in using a nebulizer. This is a video.
Tak dengar video dia?
Then
Tak dengar dia punya tu, naratif dia. Dia cakap apa?
dia cakap something. Tak dengar eh?
Dia dengar, you dengar tak?
Tak.
Saya dengar.
Saya dengar, you dengar?
Maybe sebab Imi pakai headphones kot.
Ha?
Maybe because
yeah.
Imi pakai headphones.
Pakai earphone? Kena pakai earphone pun dengar? Pakai earphone betul eh?
No. What I meant is that tadi tak dengar sebab Imi dia pakai headphone. So it doesn't.
I tak dengar. You dengar?
Okay, maybe we can try again. Imi.
You dengar? So you dengar?
Tak dulu.
Eh?
Tak dengar.
Tak dengar, apa tak dengar?
Can you guys hear it?
Ada suara, tak dengar.
Then
Ada suara kan?
Rasa kena stop apa tu? PowerPoint buka web browser.
web browser. Pardon? Should I open YouTube?
Maksudnya stop share screen and then share web browser. Macam tu normal.
Cari balik lah.
Ada?
Kena cari balik. Can you guys not hear my presentation, the video?
Dengar.
Tak dengar langsung. Wait for a minute. We search it on YouTube. History. Can you guys hear it now? Can you guys hear it now?
No.
But then,
No. No.
tak juga.
We can't hear.
You sort out later this one. This is this what you do is that you do lagi tak presentation ni?
Yeah, I can redo. I can continue with the presentation. Wait, I hope you can hear this. Yeah. Wait. Sorry for the problem that I've caused.
It's okay.
Wait for a minute.
Delivery of medication via nebulizers by Craig Smallwood.
Before we proceed, we'll also want to ensure that the patient is in the correct position. I'm going to put the head of the bed to approximately 30 to 45 degrees. An important performance note about jet nebulizers is that they should be oriented approximately vertically to work effectively. Tilting the device too far, perhaps 20 to 30 degrees on any angle, in any direction, can cause the medication to move away from the jet gas port inside the device and render the treatment ineffective. If you notice a treatment you are administering is taking a long period of time, or there doesn't appear to be an appropriate volume of aerosol generated, you may want to check the nebulizer to ensure proper breastfeeding option. If you know that then gas flow is really matter what type of gas. It could be 100% O2, air, heliox, etc. You'll need to exercise good clinical judgment to determine the appropriate gas for your treatment. Often, patients receive 100% oxygen if there are no contraindications, simply because this is the most readily available compressed gas in most institutions. But importantly, make sure that the gas flow is not running when you connect it. You should wait until the setup is complete and the device is adequately affixed to the child before you start the gas flow. This will minimize the amount of wasted drug and maximize the received dose. Next, I have our drug. I've removed the cap and I'm going to take our medication, which is in a liquid suspension, and place it inside the device. We're going to replace the cap, attach the interface, affix the oxygen tubing to the bottom portion of the nebulizer, and place the mask on our patient. I'm going to turn the oxygen flow rate on to 9 liters per minute as per recommendations by the manufacturer. This treatment should last anywhere from 10 to 20 minutes.
Sorry for the problem, but I hope you can hear the presentation or the video. Basically, this is the steps in using the nebulizer. Firstly, we put the compressor on the flat surface when it can safely reach an outlet. Second, we check to make sure all the pieces are clean. Wash your hands before prepping the medication. In the video, there are no instructions to wash your hands, but washing the hand is also important to maintain a good hygiene, and also it is a universal precaution. Next is if your medication is pre-mixed, place in the container. If you need to mix it, measure the correct amount and then place it in a container. Connect the tube to the compressor and the liquid container. Attach the mouthpiece or mask to the face and turn on the switch and check to see the nebulizer is misting. Put the mouthpiece on in the mouth and also close your mouth around it, or put the mask securely over your nose and mouth, leaving no gaps. Slowly breathing in and out until the medicine is gone. This may take 5 to 15 minutes. Next, the side effects of the nebulizer. So, what are the side effects? Actually, the side effects do not caused by the nebulizer itself, but it is due to medication that is prescribed through the nebulization process. Firstly, is the salbutamol inhalation. it can cause palpitation, anxiety, mild tremor, hypertension, dryness of mouth, and sometimes headache. For anticholinergic inhalation, it can cause blurred vision, decreased intraocular pressure, acute or worsening narrow angle glaucoma, and cataracts. For anticholinergic inhalation, it has the side effects usually occur at the eyes. So that for the patient who needs anticholinergic, we suggest to use mouthpiece usage instead of using a mask, because by using a mask, there will be leakage of nebulae mist and can affect to the eyes. Next, continue with MDI and also spacer device. So we must understand what is an inhaler. An inhaler is a portable medical device that administers medication to the lungs in an aerosolized form, which is to breathe in. It is used to relieve asthma and other nasal or bronchial congestion. There are two types of asthma inhaler, which are reliever and also controller inhaler. For reliever inhaler, it contains bronchodilator such as salbutamol and also terbutaline, and usually it is blue in color. For controller inhaler, it contains steroid drugs such as beclomethasone, and usually it is brown or red in color. So, and these are the types of the inhalers. Firstly is the pressurized metered dose inhaler. This is the standard type of inhaler that are widely used, and it contains pressurized inactive gas that propels a dose of medicine in each pump. Each dose is released by pressing the top of the canister, and this type of inhaler is easy to use, small, and convenient to carry, but it needs a good coordination to press the top of the canister and also breathe in at the same time. Second is the breath-actuated inhaler. For breath-actuated inhaler, it is an alternative to standard MDI. Breath-actuated inhalers are called dry powder inhalers. This type of inhaler doesn't contain pressurized inactive gas such as pressurized metered dose inhaler to propel medicine. So the patient doesn't need to push the canister to release the dose, but instead of pushing, this will trigger by breathing deeply through the mouthpiece. And last one is the MDI with spacer device. This is basically an inhaler such as MDI, which is attached to the spacer device. So what is a spacer device? A spacer device is important to use to improve drug deposition into the lung. It is useful to reduce the side effects of high doses inhaled corticosteroid by reducing the amount of drug deposited into the mouth. MDI with spacer device is recommended for babies and also young children because it doesn't require for the user to have any good coordination when using the MDI with spacer. Contrasting, if using MDI alone, it needs good coordination to push the canister and also breathe at the same time. And also the spacer can attach to a face mask that is suitable for children aged 0 to 6 years of age. Next is steps in using MDI and also spacer. Again, you cannot hear the video, but I try my best to overcome this problem. Okay.
Spacer. Remove caps from the spacer and metered dose inhaler. Shake the MDI for 3 to 5 seconds before using. Spray the MDI no more than 4 times before using it for the first time if you haven't used it in a while or if you dropped it. This is called priming the MDI. Insert the opening of the MDI into the rubber-sealed end of the spacer. Stand or sit up straight. Breathe out completely. Put the mouthpiece between your teeth and make a tight seal with your lips. Make sure your teeth and tongue are not blocking the mouthpiece. Press the top of the MDI so it sprays into the chamber. After spraying the MDI into the valved holding chamber, breathe in slowly and deeply. Hold your breath for 10 seconds, then breathe out normally. Only press one time. Wait 1 minute and repeat as prescribed for a minimum of 2 puffs. If you hear a whistle, you are breathing in too fast. If the medicine is an inhaled steroid, have your child rinse his or her mouth and brush his or her teeth after each treatment. Make sure you rinse and spit and don't swallow. Clean the spacer and mask once a week.
So this is a step in using MDI with spacer. So similar to the video, this is a step, but it is important to note that we must spray the MDI or prime the MDI for the first time use of the MDI itself, or if we do not use the MDI in a long time, or if we drop it. And also for MDI with spacer, and also generally in MDI, we must rinse the mouth and also the teeth, and also make sure every rinse we must spit and do not swallow, because this have complications. Next is the spacer device care instructions. So the spacer device should be washed with soap once a month and let it dry. And it should never be wiped dry, as this can cause static within the device, and dry particles will stick to the side of the spacer. And also the spacer device, we must replace it once a year, at least once a year. And lastly, in my presentation, I will talk about the side effects of the MDI. The side effects again is not caused by the inhaler, but is due to the medication that is within the canister. Firstly is palpitation and tremor, such as salbutamol, as I explained before, can cause tachycardia and also tremor, especially at higher dose. And lastly is oral thrush. Again, it's important to rinse the mouth after usage of the MDI. Steroid inhaler can cause candidiasis, particularly in the patient that doesn't wash the mouth effectively after each use of the MDI. So this is my last slide, and thank you. Any questions? And I'm sorry for the hectic of the presentation.
Okay. I think you're using the technique is not what we use. Nebulizer, yes, preferably to sit up. Tapi in children, it's not that easy. They can fight with you. So the best is to prevent the fight. If they want to lay down, well, we have to find the adjust. But the best still is to sit up. And then you put to 4 cc total of fluid. Plus at the one, if you take 1 cc Ventolin, you are at 2 cc normal saline. To 4 cc, you nebulize for 20 minutes. And then the effect is the same lah. Tapi MDI when you use ours is like this. Less than 2 years, we count to 10. More than 2 years, 5 breaths is enough. Every time you put your MDI, you chamber, you have to goncang dahulu. You press, put, breathing 5 times. Goncang, put, breathing 5 times. We don't ask the child to hold the breath. Just breathing as usual. The one is, I don't know from where is it, because the technique, standard technique in Malaysia, you press, breathing for 5 times, press, breathing for 5 times, or you count to 10. That is the standard practice. Anything else?
Nothing, doctor. I'm just apologize for my presentation.
So use the standard practice in Malaysia. The one we don't use that practice in Malaysia. Next presenter.
Hanun. Hanun Nabila.
Angkat tangan. Oh, Hanun. Tajuk.
IV intravenous line puncture and venipuncture.
Okay. Next, Isyana.
Okay, I will share my screen. Um, can you see my screen now?
No.
PowerPoint. Can you see?
Yes, now we can.
Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. I am Information Manan, and I will talk about intravenous line puncture and vein puncture. So, intravenous line puncture wait. I got some problem. Okay.
Nampak apa you punya slide? You share tak?
Oh, okay, I'll try again. Okay. Okay. Do you see my screen now? PowerPoint. That can you all see, right?
Yes, sir.
Okay. So I'm sorry, Doctor. Like my Wi-Fi is a bit slow. Okay. So intravenous line puncture, it has two types: peripheral intravenous line and central intravenous line. Peripheral intravenous line is a common method used in the intravenous therapy, and it was inserted by percutaneous vein puncture into the face.
Okay. Dengar tak? Berapa persen? Hanum?
Hanum dah tak ada, Doktor. Dah laptop.
Okay, you present, cuba besok settlekan. Siapa next presenter?
Ni.
Ha?
Okay. Amani, Nur Amani Balkis.
Ini present apa?
Lambah puncture.
Present.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Present besok.
So, Assalamualaikum and good afternoon, Dr. Fadzil and fellow friends. So today I will proceed on lumbar puncture. It is a procedure in which we are trying to inject needle into the subarachnoid space. So before we discuss further regarding lumbar puncture, let's briefly revise regarding the anatomy of spinal cord. So here we have our vertebral column. We have 7 cervical, 12 thoracic, 5 lumbar, and also sacrum and coccyx. So within the vertebral column, we have the vertebral canal in which the spinal cord is in. So knowing the anatomy of the spinal cord is important to in order to get the CSF successfully. So when we inject the needle, we are going to penetrate the skin first, and then the subcutaneous layer, and then the muscles. And after that, we will find 3 ligaments, which are supraspinous ligament, interspinous ligament, and also ligamentum flavum. So when we go through these 3 ligaments, we will feel a popping feeling. So which means we already passed through the ligaments. So after we pass through the ligaments, can you see my pointer? No. Okay. After we pass through the ligament, we will reach the meninges, and then we will reach the subarachnoid space in which the CSF is in. So CSF is what we are trying to extract in this procedure. So proceed, where do we do lumbar puncture? So usually at birth, in infant, the inferior tip of spinal cord, or is also known as conus medullaris, it ends at the level of L1. However, it ends at the level of L3. However, as we grow up, the vertebral column grow at a faster rate than the spinal cord. So the spinal cord, in adult, it ends at the level of L1. So where to do lumbar puncture? According to pediatric protocols, it is best in pediatric. It is best to be done at the level of L3 and L4 interstices. Okay, so how do physicians identify the landmark on where to do the lumbar puncture? First of all, we need to try to locate the 2 posterior superior iliac crests, and then we try to make an imaginary line that connects the 2 crests. So this line actually intersects the spine at the level of L4. So when we know where the L4 is, we can locate the spaces, interspaces, either L3, L4 or L4, L5. So that's how we determine where the landmark is. So proceed to the indications of lumbar puncture. Generally, as a general idea, lumbar puncture is done either to extract the CSF for examination purpose, or either to inject spinal medication, or also can be done to remove fluid in order to release hypertension, intracranial hypertension. So first of all, it is indicated in suspected central nervous system infection. For example, if you want to diagnose meningitis or encephalitis. And apart from that, lumbar puncture is also done in suspected subarachnoid hemorrhage. It is done to access the elevated opening pressure, which is opening pressure is the surrogate measurement of the intracranial pressure. And it is also done to see the red blood cells in CSF, or xanthochromia, which is the presence of bilirubin in CSF. And other indications include therapeutic, LP is therapeutic, lumbar puncture is therapeutic for intracranial hypertension. And lumbar puncture is also done to diagnose neurologic condition in pediatric patients such as Guillain-Barré syndrome or multiple sclerosis. And it is also can be done to diagnose pediatric neurometabolic disease, and also to instill chemotherapy drugs, and also to prevent CNS malignancies. So what are the contraindications for lumbar puncture? First is in increased intracranial pressure. If lumbar puncture is about to be done in patients with increased intracranial pressure, it can lead to cerebral herniation, because when we do lumbar puncture, the pressure at the lower area will be lower, so it will cause a shift on the of the cerebral content, of the cranial content, so it can lead to cerebral herniation. And the second one is bleeding tendency. Lumbar puncture shouldn't be done in patients which have platelet count less than 50,000 mmHg or any active bleeding disorder. And the third one is respiratory distress. So we should not do lumbar puncture in children with respiratory distress, because it can lead to hypoxemia or apnea. So we should first giving them proper airway and breathing support. Okay, and then the next one is lumbar puncture shouldn't be done when there is a skin infection at the puncture site. Why? Because if lumbar puncture is performed, it will lead to infection such as meningitis, or it can also lead to abscess. Okay, and the last one, lumbar puncture shouldn't be done in patient with hemodynamic instability. For example, in children with shock, they should first be stabilized before lumbar puncture is done. Okay, and it is important to note that although lumbar puncture is contraindicated in this patient, antimicrobial therapy should not be delayed. Okay. So these are the preparation that need to be done before doing lumbar puncture. First is we need to evaluate either the patient is fit or not for the procedure. So this is where the contraindications come into place. For example, if the children present with physical findings suggestive of increased ICP, we should delay lumbar puncture first and proceed to neuroimaging first. And after we evaluate them, if they are fit for the procedure, we need to counsel the patient and also the parents. We need to give clear explanation of the urgent indication and details. And in our society, there is a stigma that lumbar puncture can lead to paralysis, and it is actually not true. So we should counsel them clearly that it is actually a very safe procedure. And okay, and we should also get written consent, not just verbal consent. So after that, we need to prepare the equipment. So among the equipment needed are sterile glove, spinal needle with stylet, and the needle, the length is according to age. Usually in pediatric children, the length is 1.5 inch, and in an older children or in adult, it is 3.5 inch. And then skin prep, sterile grips, and 4 collection tubes, gauze and bandage, manometers in certain cases to measure the opening pressure, and also lidocaine, which is a local anesthetic, and also PPE because lumbar puncture should be done in a sterile condition, and also resuscitation equipment because we need to prepare for the worst case scenario if there is suddenly an emergency airway, breathing, or circulation problem. So that's for the equipment. So for the procedure, I would like to share a video. Sorry, stop. Can you hear the sound? Boleh dengar ke bunyi video?
No, tak dengar.
Bunyi apa tu?
So I would like to proceed. I would like to summarize the procedure.
You punya video you tak bersuara juga ya. Tak apalah, continue ha. Continue.
Okay, I would like to summarize the procedure again. First of all, we need to get the consent from the parents and then prepare the equipment. After that, sedation should be given, if possible, give it early so that it can have its effect. And then about positioning, it is important to position the patient correctly. So for position, we have either lateral recumbent position or sitting position. And we can have an assistant to assist us in holding the patient. After that, we need to identify the interspace that we want to do the lumbar puncture. So after we identify it, we can mark it to make it easier for us to come back later to puncture the site. And then first, before we puncture, we need to clean the puncture site using a standard aseptic procedure. And then place drape underneath and over the patient. And then make sure the stylet of the needle is firmly placed. And then we can proceed to position the needle in the midline of the interspace between the vertebrae of the interspace. And this is the stylet needle. And then we can gently puncture, remove the stylet and look if CSF is coming out. Okay, when the CSF is leaking, we can attach manometer in some cases in order to measure opening pressure. So when the CSF is leaking, we can collect the CSF in designated bottles. And then after that, the procedure is done. Based on what I read, it is around 30 to 40 minutes only. And then you can withdraw the needle, spray and cover with gauze and bandage. So that's it for the procedure. So for the troubleshooting, when we are doing the lumbar puncture, there are some difficulties that we might face. For example, bony resistance, in which case, when we puncture the needle, we will punch the bone. So what should we do? We withdraw back the needle up to the level of the subcutaneous tissue and try to palpate again. Make sure that the puncture site is in the midline so that we don't go to the upper spinous process or the lower spinous process. And for the second trouble is a poor flow of the CSF. So what we can do, we can ask the patient to cough or do the cerebral maneuver. And then for babies or for infants, when they cry, it can also increase the flow of the CSF. And the last one is traumatic puncture. Traumatic puncture is a condition where the spinal needle strike the penis plexus, so it will lead to blood, berdarah. Okay, so what to do? Remove the spinal needle and try to reattempt at the new site. Okay, so basically these are what that we can do if we are facing some trouble while doing the lumbar puncture. So the last one is the complication of lumbar puncture. So lumbar puncture is actually safe procedure and complications are very rare. So these two are the common complication and these are the rare complication of lumbar puncture. So the first complication is post-spinal headache. In order to lessen post-spinal headache, the physician can try to use the smallest diameter possible or use a traumatic needle. And the second complication is back pain. So back pain, actually it will resolve by itself within a few days. And the rare complication include cerebral herniation. This might happen when we do lumbar puncture in children with high ICP. And then infection, it can happen when lumbar puncture is done in patient with skin infection. And then spinal hematoma, when lumbar puncture is done in patient with bleeding disorder. And also epidermoid tumor, when lumbar puncture, when epidermoid tissue is transplanted into the spinal, into the subarachnoid space, okay, leading to tumor, and the tumor can be found like after years after the procedure is done. So that's everything from me. Thank you.
Next presenter. Siapa presenter lain seorang lagi? Hanum Nabila macam mana dapat?
Doctor, can I present first?
Silakan.
Boleh. Okay. Lokman first. Lokman, the share the screen.
Boleh, tak ada apa.
Yang folder tu tak pernah nanti saya ingat nak adjust proposal tu.
Definisi.
Tak apalah.
Sebab esok saya cuba Viber, so lepas Viber tu saya transfer.
Ya?
Lepas saya adjust tu saya print semua.
Tak apa. Dia bila dia orang nak apa tu? Suspect tak buka lagi kan? Tak apalah. You ni tapi semua nak folder tu bukan nak baca.
Esok dia print dua tu.
Nak baca. Okey. Okey ha. Sekejap ni. Okey ha.
Doctor, Lokman will share the screen.
Lokman share the screen. Kenapa ini tak dapat?
Because it's like my Wi-Fi is not stable. It's like making
duduk?
my laptop lagging.
You duduk kat mana? You duduk kat mana?
Di 9.
Di 9. Oh, what you infected by COVID ya?
You go.
9 teruk lah. Actually state
Seremban.
9.
Seremban lah, Dok.
Kat mana kena ni 9 ni?
Seremban.
Yelah kat mana
Dia
Seremban?
naik kes.
Seremban dekat mana? Stroke, tak tahu.
Tapi secara kumulatifnya memang Seremban lah. Dah sama macam Sabah dah kes tu.
Okey, tak apa. Okey, siapa? Present lah.
Saya present. Assalamualaikum warahmatullahi wabarakatuh. I am Hanun and I'll present the intravenous line puncture and vein puncture. Okay, next. Alright, intravenous line puncture, there are two types: peripheral intravenous line and central intravenous line. For peripheral IV line, it's a common procedure to do in the intravenous therapy, and it is inserted by percutaneous venipuncture into the peripheral vein. And for the second type, the central intravenous line, it is inserted into large vein in the central circulation system. For the central IV line, the advantage is that any fluid or medication that irritate the peripheral line, we will use central IV line. And also for this type of IV line puncture, it has the ability to access multiple lumens and also multiple medications at the same time. Okay, next. For the site of to puncture the blood, we have for peripheral IV intravenous, we can check the main veins or the anticubital fossa, which are the cephalic, bacillic, and medial cubital vein. But for the central intravenous line, we can the catheter terminate into the superior vena cava that leads to an area just above the right atrium. Okay, next. Okay, for the purpose of this intravenous therapy, we use this for replace fluid and electrolyte. Because sometimes if the patient is ill and fluid loss related, for example, decreased intake, surgery, vomiting, diarrhea, okay, and this is patient may require intravenous therapy lah. And for the second one, for anesthesia medication, for example, chemotherapy, anesthetic, and diagnostic reagent. For example, about 40% of all antibiotics are given intravenously. Okay, for the third one is for administer blood product. So this the donated blood from another individual. It can treat in the medical condition such as shock or trauma, or also patient with failure in production of red blood cells, so that they improve the ability to carry oxygen. And then the last one is to deliver nutrition. Because sometimes this intravenous therapy can deliver some of the nutritional requirement for person
Dulu
that
macam tu juga.
are unable to obtain amount orally. Okay. Next.
Memang dia hantar, kita ada kes KK yang hantar.
For this is the equipment for peripheral intravenous therapy. We can use gloves, appropriate size catheter. There are different types of catheter. And then non-latex tourniquet, alcohol swab, non-sterile gas, transparent dressing, 3 pieces of tape, and also intravenous bag with solution and sharp container to dispose the sharp catheter. Okay, next. This one.
Tak ada, biasanya hantar je ke klinik, tu macam biasa. Dia orang hantar, semua tak ada masalah, it's not a problem. Kita ada foto-foto. Lepas tu cuma ada tahu JNE bagaimana, kalau masa office hour tu, they will come to us. Ke klinik, datang ke klinik terus ya. Masa office awal datang ke klinik lah.
Lokman, buka caption.
Lepas tu kalau dia dapat surat. Lepas tu di surat pergi datang ke klinik, kita admit lah.
Ada subtitle. Oh tak ada.
Kalau cuma kalau after office hours kena pergi ED. Dia pergi ke ED dan ED will call us, inform us case coming. Apa level-level semua dan kita ni lah. Selama ni tak ada masalah. Kita accept case lah.
Normal tak dengar. Ke memang macam tu? Dia tak dengar Normal. Itu share web browser kan?
As long as we are concerned like case people tu, cuma bezanya lah dia have to understand.
Itu tourniquet lah. Tourniquet is to stop the.
There will be some charging kalau dia masuk ke hospital kita, because this charging is for you all.
That's it for apa? Dia puppet the vein lah.
Lain semua tak ada apa-apa.
The catheter.
The only problem is
that is the alcohol swab. To make sure they are all clean. Just to make sure that the position of the needles
tak penuh, kita accept.
Yeah, they're very open, bevel up.
Dan kita tak penuh. Ya. Tapi you have to realize kita punya SCN ni sikit gunakan 6 je. Faham dan tapi kadang-kadang
actually you want to insert the catheter, there is an angle at least 40 degree.
15 itu kita dah pecahkan sikit punya ni dan so patient datang kita nak reject kan. And then actually kita it's like before you pull the needle, before you pull the catheter, remove the tourniquet first, then remove that. Okay. Don't forget to do that. Tapi masa ni
kita insert the tube, intravenous tube.
Ada problem.
And then you aspirate and flush. Just to make sure that there is no bubble. Make sure the flow is okay lah.
Apa tu? Yang datang tu bukan tak happy, kena charge.
And then there is the tab to secure the
we accept referral, tak ada problem. Tapi make aware that there is some charge by the hospital.
And
doctor tak charge, you all in charge.
Because another thing, sometimes they put the date of when they put the catheter in on the
memang kes kita refer, kes banyak dari private.
Next, Lokman.
Sebab private dia orang patient dah willing to pay kan.
Okay, next. Okay, this is the equipment for central side. So all the sterile gloves, the sterile gowns. Lidocaine is actually a NAM AUM medication. So there's also Capet and also ultrasound. Okay, Lokman next. Actually, this depends on the video. Lokman, share the screen tak? Yeah.
Gambar apa ni?
Wait. Lokman, can you stop the video a little bit? Okay. Sekejap ya.
Oh, matilah. Pukul 2 siap kita. Pukul 2 ada meeting. Cepat sikit.
Oh, sorry, doctor. Okay, just play it. Lokman, is there any sound for this video?
Kau kena jadi macam year 5. Very efficient. Tak, we finish. And then we start ni. Because pukul 5 kan ada something else pula. It should be on than 1.5 hours. And then 1 hour 10 minutes dah.
Actually, this video is quite long, but
The long cancel lah. Kenapa you 5 boleh dapat nice video ni semua simple dia? Ni kenapa sampai yang ini you ambil yang ini?
Because this is the one.
Kebaikan you punya ni kan tak sama seperti apa yang kita orang buat. Tahu daripada mana you dapat benda-benda video ni? Video ni tak sama seperti yang apa kita praktis.
Dalam IUM punya tu.
Even yang lain tadi lain put IV line biasa je kan?
Ya.
Dan satu lagi, kalau pediatrics, I prefer you ambil pediatric punya gambar. Kenapa you ambil adult? Cancel lah this one, you dah lambat. Take new one, siapa present next one?
Me, I'll be presenting the next one. Okay, I'll just present.
Doctor, I'm sorry. I have to redo the presentation or what?
Nanti you cari yang video better sikit, present. Besok mungkin you masuk video better sikit.
Tomorrow, at what time, doctor?
Besok kita ada satu lagi kan, pukul 12 lah. Besok one more kan?
Okay.
Aisyah.
Yeah.
Okay, my name is Elisa Ahmad Hafizal.
Okay, thank you, doctor.
Elisa.
Okay.
All right, so I'll be talking about blood culture and sensitivity. So what is blood culture? Hang on. Blood culture is basically a lab test in which the blood is taken from the patient and then is inoculated into culture bottles containing the media. This is to determine whether the infection-causing microorganism, it can be bacteria or fungi or virus, are present in the patient's bloodstream. So for example, if we get like an early positive results from a blood culture, that can like provide us with valuable diagnostic information on which appropriate antibiotics or any other therapy that can be that can help the patient. Next is that when should we do the blood culture? Usually we do the blood culture before starting any antimicrobial therapy, and also at the time of fever peak, or when you suspect the patient has bacteremia or any other systemic infection, or when patient already have like a continuous bacteremia. This is like to follow up with the progression of the bacteremia. And then the site of blood culture, usually from the peripheral venous, or can even be from the arterial sites as well, can also be taken from the central venous catheters, arterial lines, inguinal vessels. But then these sites, they are more likely to get false positive result. And you can also draw blood from catheters or groin area, but then you should never perform in these sites when you have the when the peripheral site is still available. Okay, for the prohibited sites for blood culture is at the veins which are immediately proximal to an existing peripheral IV cannula. So this is because it may interfere with the samples. And also you are prohibited to take it from femoral vein because it's very hard to do the skin disinfection in this area. And also in the pre-existing medical conditions, for example, like fistula, lymphedema, or even like a stroke affecting the particular limb. And also at the areas of broken or bruised or erythematous skin. So avoid those sites. Okay. Okay. The usual site for venipuncture is basically the medial cubital vein, which is in the antecubital fossa area. And these are the main equipments that you need. So here you have the lab forms and the labels, and then you have the butterfly needle, and then plaster and tape, plastic cover or the apron, level 1 PPE, sharp bin to put the needles in, the gloves, the sterile kit, or you can also call it like a blood culture and sensitivity pack, and the gauze, tourniquet, alcohol pads, mask, and the culture bottles and labels. Okay, for the culture bottles, here is the picture of the culture bottles. Usually we would do the orange and yellow bottles, and also green. So green is for aerobic sample, orange is for anaerobic samples. Okay, so here's the video for the presentation done by the UMMC.
Procedure on taking blood sample for culture and sensitivity. Introduction. The sepsis syndrome exists along a spectrum where the patient first has an infection, which then leads to bacteremia, sepsis, septic shock, multi-organ failure, and eventually death. Early identification and management of bacteremia is vital to improve patient prognosis. Blood culture are used to aid the diagnosis and management of sepsis and septic shock. Introduce yourself to the patient. Perform hand hygiene upon entering patient area. Alcohol-based.
Oh, sorry, doctor, I couldn't find the video of, from the children.
Kenapa you 5 boleh dapat?
Oh, I'm really sorry.
Continue.
Rub upon entering patient area. Check that the laboratory form matches the patient's identity. Get the equipment and check expiry dates of culture bottle. Disposable dressing set, blood culture bottle, aerobic and anaerobic, sterile gloves, disposable plastic apron, bicutaneous needle, tourniquet, alcohol hand rubs, alcohol swab, chlorhexidine 0.5%, shops container, gauze, hyperfix, and lab request form. Perform hand hygiene. Prepare blood collection set for 0.5% chlorhexidine, gluconate in 70% isopropyl alcohol. First, open the dressing set. Arrange all items, the cutaneous needle, gloves. Use sterile gloves as this is aseptic procedure. Pour 0.5% chlorhexidine gluconate in 70% isopropyl alcohol into the dressing set. Remove the caps of the culture bottles and rub the rubber tops of the bottle with a fresh alcohol swab to sterilize for 30 seconds. Use separate alcohol swab for the two bottles. Perform hand hygiene. Apply tourniquet to the arm of the patient and identify a suitable site for venipuncture. Perform hand hygiene, wear PPE, then sterile gloves. Wear disposable plastic apron first. Perform surgical hand rub. Wear the sterile gloves. Use the gauze soaked with antiseptic to sterilize the venipuncture site. Rub antiseptic to and fro motions. Do not palpate vein again after cleaning the patient's skin. Allow to air dry first. Insert the needle into the clean venipuncture area with an aseptic non-touch technique without touching the venipuncture area. Fill the aerobic bottle first and allow the pressure to fill 10 ml of blood into the bottle. Then remove and attach the anaerobic bottle to fill another 10 ml of blood. Thoroughly mix the culture bottles by gently rotating or inverting the bottles. Once completed, release tourniquet and activate the safety device on the needle. Use the gauze to apply pressure to puncture site, apply hyperfix. Dispose all sharps into the sharps container and clear away all material. Remove gloves and wash hands. Document the patient's identification, date and time of collection, site of collection on culture without obscuring the barcode. Send bottles with a signed request form to the lab in a specimen bag within an hour of collection.
Okay, that's done for the video. This is basically the summarize of the procedure. I think you guys can read it yourself, and yeah, I think that's all from me.
Okay, next.
Thank you.
Siapa yang next?
Saya Lutfi.
Lutfi Hadi.
Yep.
Topik apa?
Height, weight and growth. Height, weight and head circumference. Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Lutfi and I'm going to present about height, weight and head circumference. Okay, for children which age 2 years and younger, we cannot measure its height, so we measure its length assessment using the calibrated length board. So the method is we need two people, doctor or healthcare professional and parents. Infant should lie on the board, on measuring board, with parent holding the infant's head against this fixed headpiece, and then the doctor strengthen the infant's leg and then bringing the feet into the contact with movable footboard, and then just measure the length of infant, and then it should be recorded into the nearest 0.1 cm. Then moving on to the height assessment. For 2 years and older, we use stadiometer, and these children should stand on stadiometer without shoes. And you see in this picture, with heels together, the leg straight, arms at side, shoulder relaxed, and the doctor should position the child head so that the eyes are directed straight ahead. And then we bring the horizontal headpiece into the contact with the superior part of head, and then we just read the measurement of height to the nearest 0.1 cm. Then moving on to the weight assessment for 2 years and younger, we weight them on the electronic scale, which has maximum of 20 kilogram and an increment of 10 gram. So the method that we use is infant should be weighed without clothing and diaper usually, and then we record the measurement of the weight to the nearest 0.1 kilogram. And then for 2 years and older, we use beam balance or digital scale that we found most. And the children should stand properly on the scale, and then we record the measurement to the nearest 0.1 kilogram. By the way, for children who are resistant to weight or who cannot stand unsupportedly, so we may need to weight children held by the parent at the same time. So in such case, we take the weight of parent or guardian alone first and note this weight, and then we weight both parents and children at the same time. Then to get the weight of children, we just subtract the total weight of both just now with the weight of parent. So we get the weight of children alone. And then for 2 years and older, we can measure BMI using this formula, weight and height square. And then the BMI values that we get just now, we can plot on the BMI reference chart. So you can see in this chart, this is age in years, and this is BMI. Sorry, this is BMI, and then if it located beyond this line is 95th percentile. So it is located, if it located beyond this line, it means that the child is obese. If it in between, it is overweight, and it is if it below than 5th percentile, it is considered as underweight. And then for 3 years and younger, we also can measure the head circumference using this flexible or non-stretchable measuring tape. So the method is we measure the maximum diameter through the supraorbital ridge over the above the eyes to the occiput in the back. And to get the precise value, we repeat this method 3 times and get the mean of it. And then we just record to the nearest 0.1 cm. And then that value we plot into the head circumference based on this age of child and the head circumference that we get just now. So if it's located beyond this, beyond the 98th percentile or beyond that 2 standard deviation, so it considered as microcephaly or probably due to hydrocephalus and so on. If it's located below than 2nd percentile or 2 standard deviation, so it means the infant, the child has microcephaly, and in between is considered as normal. Okay, this is a growth chart. It basically consists of a series percentile curve that illustrate the distribution of selected body measurement in children. So if we want to track on the length of a child on growth chart, then we have length for age chart. If you want to track the weight of a child on growth chart, then we have weight for age chart under growth chart. And usually the male one is recorded in this blue one, and then the female is plotted on this pink one. But in case for Down syndrome, Turner syndrome, achondroplasia, and also low birth weight, so we need separate own charts. So this is the CDC growth chart for Down syndrome. Not too detailed, but just want to show you the difference between the usual one and the abnormal one. Of course, the percentile and the ratio are quite different between these two. And then let's we take into an example. Sarah, 16 years old with 70 kilogram. Then we must plot the growth chart. So like usual, the below is age in years, and this vertical one is weight in kilogram. And then we just plot the intersection of this point or coordinate, and then we can see it lie on the 19th percentile. So what does 19th percentile mean? It means Sarah weighs more than 90% of other children for the same age, or she weighs less than 10% of other children for the same age. Or another way to understand it, for example, we gather 100 girls at the same time, and then we arrange them according to their weight in ascending order, starting from the lightest one to the weightest one. So Sarah, this girl, are located in 19th position. So means that there are 90% children who weigh less than her, and 10% children weigh more than her. So this is the growth chart that we found most in KK in Malaysia. Blue for boys, pink for girls, like usual. And that's all. That's my reference. Thank you.
You all kena biasakan guna yang growth chart government tu Kalau you all, the growth chart yang you all pakai is ni, tapi sebenarnya kalau you kat KKM dia pakai growth chart NHRI bukan CDC Tapi by the way sama saja. CDC yang ambil daripada National Institute of Health NIH You ambil ward hospital punya kan? So dia kat sini je pakai yang ni. I nak ubah nanti Kita pakai NHI yang semua hospital pakai. Satu. Nombor dua, you kena biasakan chart government tu Nah, chart government dan follow chart government tu you akan practice that one. Kita pakai Z score Kita faham Z score. Kita explain apa tu Z score kemudian. Okey, okey lah. IV drip tu I tak happy. Sini center line, cari yang simple punya. Lambar panca okey. Well, still apa tu? Tak apalah. Verify dapat proper punya apa tu patient blood CNS adult okey, but the technique wise is tak tahulah tapi tak apalah. Chart okey. Tapi tak apalah, it's just introduction to you all lah Sound teknik tu kita tak pakai sebab pediatric different sikit teknik dia. Tapi tak apa, I think it's okay lah for that one. Okay technical dia berbeza, technical dia prinsip is the same, principle the same. You sampai ada lagi besok kan? 4 lagi kan? Berapa lagi besok? 4. Kita buat pukul 12 juga besok. 5 juga?
Termasuk yang tadi.
Tadi cuma video je. Center line dia. Okay
Oh, center line. Dengan Benny Panca Doktor?
Panca center line dia kan. You Benny Panca ke center line Benny Panca? Yang tunjuk gambar apa tadi? Yang tunjuk gambar apa tadi?
Oh, yang video tadi tu itu peripheral IV line. Yang belum lagi central line dengan Benny Panca tu je. Dua tu belum lagi video lah.
Okey Okey.
Doktor, maksudnya nak video yang simple-simple lah. Jangan pediatrics kan, Malaysia.
Ada simple je. Kita tak letak macam tu complicated nampak gaya.
Okay.
Center line kita buat semua simple je. Okey.
Alright.
Besok pukul 12 kan?
12 hari remaining.
Right.
Sorry geng, alright. Sorry.
Selamat ya Fatih.
Sorry. Saya delay lah. Tak apa, saya siapa-siapa yang tolong.
Alright, thank you. So,
good job. Nanti all the best.
Good job.
Okay.
Pukul 12 ya, Sok? Uh,
Yep.